Goals really are to appreciate the role of ultrasound in breast imaging, specifically in three areas: screening, where we do some screening with ultrasound; diagnosis, we do quite a lot of diagnosis, where we try to help clarify palpable abnormalities or mammographic abnormalities; and also guiding procedures. Ultrasound is a very common way that we biopsy breast lesions currently. There is screening breast ultrasound. We do it at our institution. It is gaining in some areas of the country. And we know that if we do screening with ultrasound, we can find cancers that are not identified mammographically. So this would be for asymptomatic women without a personal history of breast cancer. Even though the mammogram would be negative, we can find cancers in roughly 3 or 4 per thousand, oftentimes significant cancers. The bulk of what we do in breast ultrasound is diagnostic work, where we have abnormal findings on screening mammography, or we're looking at patients who present with signs and symptoms of breast cancer, or they have a history of breast cancer and they're coming for surveillance, or sometimes when we're evaluating patients with breast implants. Ultrasound really is an indispensable tool in breast imaging. In terms of screening, we tend to restrict that to women who have dense breasts, because the dense breast tissue may obscure underlying breast findings, and also probably that dense tissue is slightly proliferative, in other words, more likely to cause lesions. And on the diagnostic side, we use ultrasound to evaluate palpable abnormalities, to evaluate areas of breast pain, to try to determine if a lesion is real. For example, a lesion that had been seen on screening, and we want to try to determine, is it real or an overlap? And also we characterize masses to determine perhaps if it's a cyst or a typically benign appearing lesion, or perhaps a more worrisome lesion. And then we would embark on doing perhaps a biopsy using ultrasound guidance. And another area that we use our ultrasound for on a daily basis is what we call determining the extent of disease, or staging, really determining how much cancer is there. Is there cancer in another quadrant? That would make it a multicentric disease, or more than one lesion in the same quadrant, which would make it multifocal disease. So when we're doing staging, we're looking for satellites, trying to determine if there are lesions in addition to the main lesion or the previously biopsied lesion. And ultrasound helps us to determine the management for the patient. And in this study by Dr. Moon and colleagues, there were about 200 patients with newly diagnosed breast cancer, and ultrasound showed mammographically occult multifocal or multicentric disease in 14% of the patients, and contralateral breast cancer in 4%. So these findings resulted in change in management of about 16% of the patients. So in terms of using ultrasound for procedures, it has a number of advantages. There's no ionizing radiation. There's no IV contrast. It's one of those modalities where you can continuously monitor your needle tip, so you see where your needle tip is at all times. So that's particularly important if we're near the chest wall or near an implant. Also, when we compare it to stereotactic biopsy or MRI-guided biopsy, it's faster, it's cheaper, and it's more comfortable for the patient. In terms of our possibilities for ultrasound-guided procedures, we can do fine needle aspiration, we can do core biopsy, we can do needle localization, and we can place markers. For example, after we biopsy a lesion and it's known to be cancer or presumed to be cancer, we can place a metallic marker there. We can also place radioactive seeds or magnetic seeds or other localizing devices, so that would help guide the surgeon for appropriate excision when the lesion goes to surgery. Most breast biopsies can be performed with 14-gauge core biopsies. There are vacuum-assisted ultrasound-guided devices which can be used for small masses, for intraductal or intracystic lesions, or sometimes for lesions with subtle calcifications. In general, ultrasound is complementary to mammography. We tend to use them in an intertwined fashion in breast imaging. And in general, most masses are evaluated with mammography and ultrasound, and oftentimes biopsied under ultrasound guidance. Ultrasound is a limited role in evaluating calcifications. Sometimes we can see calcifications and biopsy them under ultrasound guidance. As you can see, in this case, there are retroareolar calcifications, very fine amorphous calcifications, and we can see some specular reflectors on ultrasound. This would be an example of benign calcifications. This case did undergo biopsy. Ultrasound is also complementary to MRI. MRI can help us to define findings that we see on ultrasound, and ultrasound can help us to find findings that were seen on MRI, and then if we can go back to the ultrasound or do what we call a target or second look ultrasound, that may facilitate ultrasound-guided biopsy. When we think of ultrasound in terms of masses, we really break it down into cysts and solid masses, and now we can think of masses in terms of benign masses, likely benign, such as a fibroadenoma, or malignant masses, such as invasive ductal carcinoma. When we think of cysts, they really usually are circumscribed, anechoic. They have thin walls with enhanced through transmission, and we can characterize these very well with ultrasound. And when we think of our normal ductal system, we can understand cysts as really ductal dilatation, where the ducts dilate into a finger-like or glove-like structure, and then eventually turn into round or oval lesions. This would be kind of the characteristic way of thinking how cysts are formed. And here we see an example of a bilobed cyst with good through transmission posterior to the cyst, as you see here. And here's just another cyst. As you can see, there are a few internal echoes. There are a couple cysts together, and there is through transmission here. So when we find cysts, really no additional imaging is needed. No additional intervention is needed unless it's extremely painful and the patient desires aspiration, or perhaps it's thought to be infected, and then we're going to send the material to the laboratory. Now, what about this case? Is it a cyst or a solid? It's oval, hypoechoic. There are definitely internal echoes, as you can see with the arrow, and we did wind up putting a needle in it, and we can see that when we put our needle in, as you can see, the echogenic structure, the lesion collapsed during FNA, and cytology showed apocrine cells in a background of proteinaceous fluid consistent with cyst content. So basically, the internal echoes, I'll just go back one here. The internal echoes basically were proteinaceous material. And then this lesion entirely collapsed during the FNA. And solid lesions can be characterized as benign or malignant. This is work that was started by Dr. Stavros and his colleagues in the late 90s. When we're doing our ultrasound, in general, we would want to be between a 12 and 5 megahertz. And to look at the superficial structures, or in small-breasted women, we'll go to even higher, like 17 to 5 megahertz. Sometimes in the same case, we may need to vary the transducers to evaluate both superficial and deep structures. And ultrasound can also help us in evaluating and looking at skin thickening and skin lesions. This is a patient with inflammatory breast carcinoma. Note where the arrow is, there's marked skin thickening in this patient, and also quite a lot of trabecular thickening in the breast. And here we can see when we look at this extended field of view ultrasound, we can see the skin thickening demarcated by the S, and also there's associated subcutaneous edema, as you can see with the arrow here. With ultrasound, we do real-time scanning, so this can help us for detailed analysis of lesions, particularly if we're looking at lesions that may be malignant with indistinct margins or multiple projections. We can evaluate region of architectural distortion, and also we can do direct assessment of palpable abnormalities with ultrasound. When we think about ultrasound, we have a number of tools, and many of these things can be done simultaneously now, as we have very fast processing. In general, our backbone is grayscale imaging. We also oftentimes use harmonic imaging. This employs the resonance characteristics of the tissue, and then we can harness other harmonic waves, and this basically allows us to have fewer artifacts and better image quality. We can use both color Doppler and power Doppler to look at flow, and power can help us especially with slow flow. We can look at elastography to look at the firmness of a tissue, and there are techniques for 3D imaging. In addition, we employ compound imaging. Basically, this is a technique that uses beam steering to rapidly acquire multiple scans of an object from different angles, basically 3 to 10 overlapping scans, and then these are averaged to give us what we call a compound image, so to speak. And let's just take a case as a 35-year-old woman, If we look in the medial retroareolar region, there's a rounded mass here. And you can see it by the arrow. So, fairly well circumscribed margins. And the next step would be to evaluate this lesion with ultrasound. And on ultrasound, we see a oval mass with a parallel orientation. There are definitely internal echoes. Probably it's going to be a benign lesion, but it doesn't really fit the criteria for a cyst for sure with the internal echoes. And when we look at the longitudinal image, perhaps the margins aren't as smooth as we would like for a typically benign lesion. And here you can see with the harmonics, this perhaps allows us to have maybe fewer artifacts and better image quality, especially when we're looking in the region of the posterior area of the lesion. And notice there's a little bit of edge shadowing on either side of the lesion. And with power Doppler, we can see the flow mainly peripheral. And power Doppler is quite good in ultrasound, especially when we're looking at slow flow in small vessels, as you see here. A nice example of peripheral flow with power Doppler. In this particular case, we did FNA, fine needle aspiration. As you can see, our needle tip is in the lesion, and cytology showed benign ductal epithelium. So it would fit with our thoughts that this was a benign lesion. When we're setting up our scanning parameters, we want our pectoralis major in the posterior margin of the field. The fat should be a mid to level gray, and simple cysts should be anechoic. Most solid masses are hypoechoic compared to fat. When we think of the echogenic structures, those would be Cooper ligaments or sometimes fibrous tissue. And here's just an example. The M stands for the pectoralis major set at the posterior aspect of our field, and the arrows are pointing to echogenic areas associated with Cooper's ligaments. And sometimes just in a normal heterogeneous background, we can see echogenic areas representing some fibrosis, basically just a normal background in a heterogeneous or busy breast. We want to be able to correlate between mammogram and ultrasound, as well as between ultrasound and MRI. For example, we want to correlate lesion depth, the surrounding structures, and the distance from the nipple. When we look at vascularity, power Doppler is more sensitive than color Doppler for evaluating low flow volumes in breast lesions. That can help us when we're evaluating solid masses, when we're evaluating cysts and complex cystic masses as well. And elastography is really based on observations that malignant tumors tend to feel hard compared to benign lesions. And we can harness that and get some quantified analysis when we use elastography to evaluate breast lesions. With strain elastography, there's gentle compression that results in tissue displacement, or so-called strain, and strain is decreased in malignant masses. With shear wave elastography, this is based on an acoustic radiation force. So with light transducer force, there's automatic pulses that are generated by the probe, inducing a transversely oriented shear wave. This is less operator dependent compared to strain elastography. And we need to correlate our findings between elastography and grayscale ultrasound. For example, you could potentially have a hard benign mass and a soft cancer, so we definitely need to correlate between the two modalities. 3D ultrasound is emerging. There's possibilities for improved characterization of malignant lesions, especially if you think of a lesion with spicules going in multiple directions, perhaps for better delineation of multifocal disease. And also there really is a potential role for assessing response to neoadjuvant chemotherapy, because we know that lesions being treated with neoadjuvant chemotherapy don't shrink down concentrically, but more in an irregular or asymmetric fashion. So for benign appearing masses, overall they're oval, they're wider than tall, they're parallel to the skin, they tend to have circumscribed margins, or they may have gentle and smooth lobulations. For malignant features, they tend to have spiculations, angular margins, they tend to be hypoechoic, they tend to have posterior shadowing, they may have microcalcifications, they may have ductal extension toward the nipple or a branching pattern where ducts are extending away from the nipple. They may have 1 to 2 mm microovulations, may be taller than wide, and may be non-parallel. Most cancers we know have greater than one malignant feature. Speculation is probably the most specific for malignancy. If we think about what a typical malignancy would look like on mammography, that tends to make sense. And angular margins are one of the most common findings that we find in malignancy on ultrasound. So according to Stavros' paper in Radiology, if we used his criteria for benign versus malignant, we could come up with a negative predictive value of 99.5% and a sensitivity of 98.4%. So this work in the late 90s by Dr. Stavros and his colleagues sort of laid the foundation for the BI-RADS ultrasound or the breast ultrasound lexicon. And this really allowed us to have better data tracking, to carefully describe lesions, and have more precise communication with our clinicians. So as you know from BI-RADS, there are 6 categories ranging from 0, needs additional imaging, 1 is negative, 2 is benign, 3 would be probably benign, like a less than 2% likelihood of malignancy. And then 4 has been divided into 4 categories. That would be 4 for suspicious, but 4A is low suspicion, 4B moderate, and 4C high suspicion. And then category 5 is highly suggestive of malignancy. That would mean that the probability of cancer would be greater than 95%. And 6 is a known biopsy-proven malignancy. And the next BI-RADS, we're not sure when that'll come out, but there may even be another category, perhaps for lesions that have been treated non-surgically that are being followed. So that probably will be a part of the next BI-RADS. So let's go through the BI-RADS lexicon a little bit here. So in terms of mass shape, we have the categories of oval, round, and regular. And we can see in this particular example, it's irregular, and orientation would be either parallel or non-parallel. And in this example, which was an invasive ductal carcinoma, it's definitely non-parallel. And how about for mass margin? Our choices are circumscribed or then non-circumscribed, where we have a few choices such as indistinct, angular, microlobulated, or spiculated. And in this particular case, it's definitely not circumscribed, and I would say the margins are indistinct. And in addition, we can look at the echo pattern. In general, most of our malignancies will be hypoechoic. Most of the lesions we see in breast imaging will be hypoechoic, as we see here. The choices are anechoic, hyperechoic, complex cystic and solid, hypoechoic, isoechoic, and heterogeneous. And also we look at posterior features, such as in this one, there's shadowing. Other choices are no posterior features, enhancement, as we may see in a cyst, or a combined pattern. And then the BI-RADS ultrasound has other descriptors. There are descriptors for calcifications, for associated features such as architectural distortion or duct changes, and then special cases such as a simple cyst or a clustered microcyst, etc. But the majority of our work in ultrasound will be with masses and using these major categories that we discussed, such as shape, orientation, margin, echo pattern, and posterior features. We also can use extended field of view imaging. That can be helpful. That can allow us to image beyond the footprint of the transducer. That can be helpful for measuring larger lesions, for measuring the distance between lesions, or measuring the distance between the lesion and the nipple. So we can see in this particular case, this is a high-grade invasive ductal carcinoma. We're measuring the distance between the lesion and the nipple, which is marked by an N here. So when we look at BI-RADS, if we were to look at this case, it's irregular and it's parallel. This was invasive ductal carcinoma. In this particular case, we can say the margins are not circumscribed, they're indistinct. And again, this was invasive ductal carcinoma. And as we discussed, most breast lesions will be hypoechoic, and this was definitely hypoechoic invasive ductal carcinoma. There can be overlap. There could be some benign focal fibrosis or postoperative scars that could mimic irregular shadowing that would be characteristic of malignancy. For example, a high-grade invasive ductal carcinoma with central necrosis or a well-differentiated mucinous and medullary carcinoma, they could look oval and hypoechoic and mimic a complicated cyst with low-level internal echoes. So there can be some overlap, and we have to basically be very careful, use detailed scanning, use all of our tools at our disposal. Echogenic masses are usually benign, such as lipomas or areas of fibrous tissue. Echogenic tumors rarely occur. DCIS is usually seen on mammography as microcalcifications. Some calcifications in a hypoechoic mass can be visualized on ultrasound, and sometimes in those cases, the hypoechoic mass may be an associated invasive component. Non-calcified DCIS can occur as a solid mass. This is more frequent in non-high grade than in high-grade DCIS. And also, we can use ultrasound to help evaluate nipple discharge. Ultrasound can be used as an alternative or in addition to ductography. Ultrasound may identify a retroareolar or an intraductal mass and facilitate ultrasound-guided biopsy. So here you can just see in this particular case, we get a nice view of some mildly dilated ducts in the retroareolar region, and if there were an intraductal mass, we would be able to hopefully identify it and perhaps perform a biopsy if need be. At the outset, we discussed screening ultrasound, and screening breast ultrasound is whole breast ultrasound designed to be supplemental screening in patients with dense tissue seen on mammography. The range is between 2 to 3 to 4.6 mammographically occult cancers identified on ultrasound per 1,000 women screened. The cancers identified on screening ultrasound are usually small, less than 1 cm, node-negative, invasive cancers. Screening breast ultrasound can be done by physicians. It could be done by trained mammography technologists, or it could be performed by sonographers. With this, you need particular attention to detail, need optimal scanning technique, and really need to make sure you cover the whole breast. Somewhat similar to if you're cutting the lawn, you just need to make sure that you cover all of the potential area. Let's take this case, 75-year-old woman, status post-left mastectomy for DCIS, very dense tissue, some vascular calcifications. Then we go to the screening ultrasound in the right breast at 3 o'clock. We see a hypoechoic mass with ill-defined margins, and this was invasive ductal carcinoma identified in screening ultrasound. Screening breast ultrasound is operator dependent. We would aim to identify small node-negative cancers, and it has a very limited role in identifying small groups of clustered microcalcifications. The identification and the biopsy of calcifications is better handled with mammography and stereotactic biopsy. So when we're doing automated screening breast ultrasound, there are units that are automated with big probes, for example, with a 15 cm transducer. These type of automated units can produce over 3,000 overlapping images in the sagittal transverse, and including the coronal view, which can be a helpful view. The images are then viewed by the radiologist on a workstation. It appears this may have less operator dependence. It can allow for greater radiology efficiency after they tackle the learning curve associated with the workstation, and increased reproducibility. This may aid in the follow-up of some lesions. And when we look at some data, a multi-institutional study of automated whole breast ultrasound found 3.6 cancers per 1,000 women screened, so that's very similar to handheld screening breast ultrasound. So it appears that screening breast ultrasound can be performed fairly well, either with a handheld technique or an automated technique. When we look at ultrasound following MRI, lesions detected on MRI can be occult on mammography. Many of these lesions will be detected first on MRI, and then ultrasound will be used to see if we could find the lesion on ultrasound. If we could find it on ultrasound, then we could do the biopsy under ultrasound, where it's cheaper, quicker, and more comfortable. If the MRI identified lesion was not seen on ultrasound, then it would be biopsied under MRI guidance. So let's take a look here. A dense tissue, and we don't see particularly too much here. We see in the upper part of the image over the pectoralis muscle, we see what looks like a lymph node. When we go to the MRI, we can see that there really is marked lymphadenopathy there. So this patient was presenting with an unknown primary with axillary metastatic disease, and then the MRI was being performed to see if we could find a primary. So here on the contrast-enhanced MRI, we see multiple small enhancing masses and some associated non-mass enhancement. Then we would next try to go to ultrasound to see if we could find a correlate. And here on ultrasound, we found this hypoechoic mass in the left breast at 2 o'clock. This was shown to be invasive ductal carcinoma. And another 2 o'clock lesion here in the left breast at 2 o'clock, shown to be invasive ductal carcinoma as well. So on second look or targeted ultrasound, then masses that we see on MRI are more likely to be identified compared to areas of non-mass enhancement that we see on MRI. And the masses were identified in perhaps 58 to 65% of cases, whereas non-mass enhancement would have a correlate in 12 to 32% of cases. Let's take a look at this patient, BRCA1. So the patient is being screened with mammography and breast MRI. The mammogram appears unremarkable. CC views here. Here's our MLO views. Then we can see on the MRI, we have found an enhancing mass with washout kinetics. Here we see it both on the sagittal and the axial views. So next we would go to ultrasound to see if we can find a correlate. And here under ultrasound, we find a very small hypoechoic mass in the appropriate location in the left breast, 11 o'clock, corresponding to the finding that we saw on the MRI. And now when we look at the lesion, we can see that it's hypoechoic, slightly irregular. And if you look to your left, you can see that there actually are some spiculations that we can sometimes see under ultrasound. So this was a worrisome lesion. And we did the ultrasound-guided core biopsy, and this was invasive ductal carcinoma. So we want precise MRI ultrasound correlation. If we're not sure that the finding on ultrasound may match, or we're not sure if it fits with the MRI finding, then we should go to MRI-guided biopsy if the lesion was thought to be suspicious on MRI. Ultrasound can also help us to look at the lymph nodes. It can be helpful in evaluating the lymph nodes in the axillary, supraclavicular, and internal mammary regions. In general, abnormal lymph nodes will have focal or diffuse cortical thickening, usually greater than 3 mm. They will have a round shape. Normal lymph nodes tend to be oval, and then as they become malignant, they tend to move more towards a round shape. And there would be a loss of the echogenic fatty hilum, also with non-hilar, disorganized, irregular blood flow. And also, if we find biopsy-proven axillary lymphadenopathy, that usually results in a management change. So if the axilla is involved, that would result in neoadjuvant chemotherapy. Oftentimes, the plan would change from sentinel lymph node biopsy to axillary dissection. And also, we would sometimes perform a clipping of that metastatic lymph node, and then that may facilitate targeted axillary dissection where the clip would be localized, and then the known metastatic lymph node would be removed at the time of surgical excision. So here's just an example of a metastatic axillary lymph node. As you can see, the hilum is displaced, the hilum is flattened, and right in the area of the arrow, there's marked cortical hypertrophy there. And here you can just see that there's quite a lot of of cortical flow. This is adjacent to the hilum where there's disorganized cortical flow here, as we see on power Doppler. In terms of biopsying axillary lymph nodes, it can be done with FNA or core biopsy. It would depend on what your situation is regarding cytology support. If you're doing FNA, that would require proper slide preparation and a skilled cytopathologist. If this could be done on site with the cytologist, that would be the best situation. Also, if you're going to biopsy a supraclavicular or internal mammary lymph nodes, those would require an FNA. If you're lacking appropriate cytology support, then for axillary lymph nodes, then you would want to pursue core biopsy. Here's an example of an enlarged left axillary lymph node. This patient had a known malignancy in the breast. You can see that there's slightly uneven lobular cortical thickening. And here we did our core biopsy. You can see the biopsy device in the upper part of the cortex here, and that showed evidence of invasive ductal carcinoma. So in general, ultrasound facilitates identification, characterization, and biopsy of breast lesions. Currently, ultrasound plays a major role in the management and treatment of breast lesions It really is an indispensable component of modern day breast imaging. To make breast ultrasound go and to make it efficacious, we have to optimally use the technology. That tends to mean that there has to be meticulous scanning, both in terms of coverage and in terms of attention to detail when looking at a finding, and then also to synthesize the findings from mammography, from MRI, to do correlation between those modalities is the best way to use ultrasound. And then, of course, ultrasound is our main way for guiding biopsies of masses. In the future, we'll see ultrasound units become smaller and faster with greater real-time processing capability. We'll be able to do more of our special imaging, such as harmonic and compound, simultaneously, or we'll also see more advances in elastography and see how elastography and other developments, such as contrast-enhanced ultrasound, can help us to be more precise in our diagnoses. I think we'll continue to have integration of multiple modalities along with artificial intelligence. Breast ultrasound is not a standalone modality. It's heavily integrated with mammography and heavily integrated with MRI. And we'll probably see personalized medicine, personalized risk stratification, and personalized imaging, so one size may not fit all. Thank you so much, and we appreciate your attention. Thank you very much.